Okay, I'm gonna start off with my machine check. So I'm gonna make sure my machine's plugged into AC power. I'm gonna crack my O2 auxiliary tank and make sure it's at least half full. Close it. Gonna check my PSI pressures and make sure all my gases are at least 50 PSI, which they are. I'm gonna look at my vaporizers and make sure that they are full, that the caps are on tight, and that the interlock system is working. While my machine's still off, I'm gonna do my low pressure leak test so that my flow meters make sure they don't have a leak in them. Then I'm gonna make sure that my monitors are turned on and that the appropriate alarms parameters are set for them. That I have an EKG, blood pressure cuff, and pulse ox ready to go. That suction is working. My ambu bag also works as well. And then I'm gonna do my high pressure test. So I'm gonna close my APL valve to 70, include the wide piece, and apply positive pressure of the flush valve. I should be able to maintain 30 centimeters of water for at least 10 seconds. And I should be able to apply a positive pressure breath as well. And I'm watching my in-spray, X-ray flutter valves. I'm gonna open my APL valve so my patient can breathe spontaneously. And I'm gonna look at my CO2 absorbent, make sure that looks good. I'm gonna check my vent settings for my patient. I'm gonna do my O2 analyzer test as well. And I'm gonna make sure that the interlock system is working, or the Link 25 system, and make sure I can't create a hypoxic mixture. So I have my 708 tube for my patient, a half size of below and above, and I have my Miller 3 blade that I'm gonna use for DL. And then I have oral airways and LMA for backup. Okay, and then I have my Apple's drugs ready as well, prepared, and my induction drugs. And then I also have my tape as well, tape rice. So now I'm gonna introduce my patient. I have a 29-year-old female. She's 60 kilos. She's 180 centimeters tall, and her BMI is 18. Past medical history includes hyperthyroidism, which she's currently in remission for, and a previous tib fib fracture. She is here for a shoulder arthroscopy, and I'm planning on a general anesthetic with an intubating with the ET tube. And I'm going to be doing an ISB block for intra-op pain management and post-op as well. Okay, I'm going to do her airway exam. So her Malapati, she is a class 3. She's got good range of motion with no paresthesias. Her upper lip bite, she's a class 1. Her thyromental distance is adequate, 6 centimeters. And her incisor gap is within normal limits. It's 6 centimeters as well. Next, I'm gonna auscultate heart and lungs and ask her some questions about her physical exam. Have you ever had a history of strokes or seizures or any paresthesias I need to know about? Any chest pain, single episodes or heart problems, any asthma, any liver kidney disease, diabetes, any exercise intolerance. And then I'm going to ask about NPO status. So what did you have for breakfast? Any recent cough, cold, or flu? Any history of anesthesia problems in the past with you and your family, such as malignant hyperthermia or post-op nausea and vomiting? Have you ever been hospitalized? Next, I'm going to review patient labs and chart anything pertinent in her history. And I'm going to explain the risk benefits indications for this procedure. So for the ISB block, you can get some diaphragm hemiparesis due to the phrenic nerve involvement, and then you can also get Horner syndrome, and you can also get some intravascular damage or last from local injection, and you can also get infection, hematoma risk, and you can also have nerve injury with this as well. However, the benefits are really great. Patients really love it because it gives such great anesthesia in the OR, and then also post-op pain control is awesome as well. It also reduces the opioid use and all the risks with opioids such as constipation and dependence, and then also reduces the risk of nausea and vomiting, and like I already mentioned, patient satisfaction. So I'm gonna get the patient consent, and next I'm gonna get my equipment ready for my patient. So I'm gonna get my ultrasound, the probe cover gel, and then I'm gonna get my 22 gauge needle and my Marcaine that I'm using as my medication, my skin prep and drape, and I'm gonna put on my PPE. So I'm gonna meet my patient. So let's see, I'm standing on that side. Okay, so after I've prepped and draped my patient, I have my gloves on and my sterile PPE. I'm gonna use my high frequency linear array, so my 10 to 12 hertz transducer. And then I'm gonna find the anterior and the middle scalene, and I'm using the clavicle as a landmark as well. And a really great landmark is C6, which is the cricoid, just the cricoid. Okay. All right. Okay. And then I'm going to place my transducer in the transverse position here. Okay, so you can see the anterior and the middle scalene, and here is my landmarks, and the sternocleidomastoid is like this little, I don't know, decrescendo muscle up here. And then we have C5, 6, and 7 as the nerve roots right there. And so for my injection, I will prep with the skin wool with lidocaine, and then I'm gonna use for the technique a 22 gauge needle with a 5 centimeter length, and then it's insulated, it's a B bevel, and then my needle approach is lateral to medial just to avoid that vasculature that's up here in the anterior spot, and then slightly caudal as well. So medication, I'm going to use Marcaine 0.25%, and then I'm going to do 5 ml increments around each nerve root, so a total of about 15 to 20 mLs of volume. And I want good circumferential spread around each nerve root. Okay. So now I can bring my patient back to the OR. I'm going to get the appropriate monitors on for my patient and get them in a really good position with good sniffing position so I can align their axes for a successful intubation. And I gave them 2 milligrams of Versed in pre-op, so they're already a little sedated and happy. So now I'm gonna use the EC technique to hyperoxygenate my patient for 3 to 5 minutes. Turning up the O2 6 minutes here. And I'm making sure that the nose is covered and getting a nice good seal to not denaturate my patient. Okay, and now I'm going to be able to do my induction drug. So she's going to get 100 of fentanyl, followed by 120 milligrams of prope, and then last is 60 milligrams of Sux. Then I can tape the eyes, and I'm going to deliver a positive pressure breath. Make sure I can deliver a good breath, which I can. Next, I'm going to use my Mac 3 blade for my DL and my 70 ET2. I'm going to get that through the cords, and as I get through the cords, I'm pulling the stylet out. I'm going to auscultate for breath sounds bilaterally and look for misting of the tube, look for my capnography to make sure that tube is where it should be in the airway. Which I get confirmation of, so now I can tape my ET tube here at 21 centimeters. Tape that down. And then I can turn my maintenance SIVO to 2%. Okay, so for extubation, I'm choosing to extubate this patient deep because they don't have any risk factors. such as GERD or full stomach or OSA, obesity. So deep extubation can have a higher risk of obstruction and aspiration, but it does decrease risk of coughing and waking up agitated. So, okay, now I'm going to go to PACU and introduce my patient to the post-op nurse. This is my patient, 29-year-old female, 60 kilos and 180 centimeters, BMI 18, past medical history of hyperthyroidism and prior ortho procedure on the left lower extremity. She got a general anesthetic with Proproc and Fent. She's been fully reversed, and she was extubated deep. And we did an ISB block and pre-op to help with post-op pain and intra-op anesthesia. I did use a neo-drip throughout the case to maintain good blood pressure because she's in that beach chair position. Estimated blood loss was 100 mLs, and then urine output was 250. I gave her 500 mLs Belar in the case. And post-op pain will be controlled with the ISB block, and then you can also give IV Tylenol a gram if you need it, and then you can also do 4 milligrams of Zofran as needed for nausea and vomiting.